Okay, I think I'm going to go ahead and get started. Welcome to the PAGNY Health and Research Foundation Grand Rounds, our clinical research presentations for today. Few housekeeping items. We are recording this so we can archive it on our foundation website under the events and programs section, which you can see the link on your screen there. And also it should be coming into your chat room, so you can click on that as well. We will have questions and answers after each presentation. So please feel free to unmute at those times and or type your questions into the chat room and we can read your questions. Please make sure to sign in for your attendance to claim any CEs through the EEDS text messaging method or website portal using the sign-in code that I will provide in just a second. After completing the sign-in and evaluation, you will receive a certificate. Please complete the evaluation certificate that will be sent to you at the end of this program, which is required to receive your CEs and gives us wonderful feedback. Thank you. Okay, so here's today's CE sign-in. The activity sign-in code is 40 draft, and this is for half a credit. Sign-in methods are text code to 828-295-1144 or visit eeds.com or EEDS iPhone Android app. And event disclosure for today is Dr. Yu and Dr. Truesdale have no relevant financial relationships to report in the last 12 months with a commercial interest, and this activity is not commercially supported. Some programs coming up. February 5th, we had a technical incident with the last Wednesday's CE program, Grand Round program. We will be rescheduling it for Friday. It is rescheduled for Friday. The topics are the role of contralateral extremity X-ray in the diagnosis of fractures after trauma. Topic 2, application of procalcitonin to febrile children in the emergency department by Dr. Mohammed Wasim. And then next Wednesday, we will start our self-kindness programs for the next few weeks. So keep those in mind, and please register. I believe CMR is putting in the registrations into your chat box as we speak. So let's get started. Let's start with Dr. Yu first, the impact of the COVID-19 pandemic on burnout, PTSD, coronavirus anxiety, and compassion fatigue among staff at Bronx Hospital. Dr. Yu, take it away.
Hello, everyone. I'm a resident from Lincoln. I'm here to present my work on COVID-19 and stress-induced mental health concerns among our healthcare workers. Next one. So as we all know, since COVID-19 continued to spread around the world, healthcare workers are facing a range of stressors on a daily basis, including tremendous increase in workload, exposure to life-threatening disease, and shortage of resources. All these might have caused mental exhaustion and even psychological disorders like depression, anxiety, distress. On the other hand, healthcare workers also facing indirect impact from the traumatic events their patients are undergoing. So this is usually referred to as secondary trauma or secondary stress. These might affect their approach to their work and taking care of the patients. We use professional quality of life. This is a scale we use a lot to assess the impact of caring for patients suffering from traumatic situations on basically 2 dimensions. First one is compassion satisfaction. It is the positive aspect of ProQual, professional quality of life. So it actually tells you the pleasure and self-appreciation derived from helping patients going through a traumatic situation. The other one is called compassion fatigue. This is the negative aspect of ProQual. It tells you that the physical, emotional, spiritual depletion associated with caring for significant emotional pain or physical stress undergone by the patients. So compassion fatigue composed of burnout and secondary traumatic stress. So the difference between these two are like burnout sort of like cumulative status, progress over time. Secondary traumatic stress usually occurs suddenly in response to a specific event. Next one. So we conduct a retrospective, cross-sectional study in our hospital. The duration of this study is from May to July 2020, right after the spring outbreak of COVID. So we send out de-identified and self-administered questionnaire to all employees in Lincoln. Basically, so this survey composed of two sections. The first section, we actually asked for demographic information, age, gender, race, their primary role in the hospital, their years of experience, any prior history of behavioral, emotional health issues, their exposure to COVID and residential status, etc. The second portion of this survey composed of different scales for mental health problems, including professional quality of life, PTSD, and we also included two newly developed scales to assess the anxiety and obsession with COVID-19. Next one. Next one.
Yes. Is it there? That is
Yeah.
the
So this is the result. This is the result. In total, we have 889 participants who completed the survey. Out of 1,200 participants we sent this survey to. As you can see, all the participants distributed evenly along the age group. 73% of the participants are female, 21% are white, 80% are non-white, 33.7% identify themselves as Latinx. More than half of them has like bachelor or graduate degree. 20% are physicians, nurses, or light healthcare workers who are in direct contact with COVID patients. More than half of them has like working experience of more than 10 years. 60% provided clinical care to patients. 5% of them tested positive for COVID personally. More than half of them has at least one family members or close friend tested positive for COVID. We have 41 participants, which is like 4% of the total participant who had like prior mental health problems. More than half of them have like children or elderly people to take care of at home. 45% of them has their primary role changed during the outbreak. What does that mean? We have like nurses like who used to work in floors had to function like an ICU nurse. Like people from the administrations are redeployed to the triage area to screen patients. Next one. So this is the second part of the result. On the left side, you can actually see the prevalence of compassion satisfaction and compassion fatigue. We only have 4 patients who reported low compassion satisfaction. 1 patient reported high burnout, and 5 patients reported secondary traumatic stress, which means overall, our participant reported high compassion satisfaction and low compassion fatigue. In another word, that's like a high standard professional quality of life. But still, we see quite a few participants who reported positive PTSD, 24%. 8.8% of them has like anxiety, and 20% of them has like obsession. And compassion, so high burnout and secondary traumatic stress strongly predict those three trauma-related mental health problems: PTSD, anxiety, and obsession. As you can see, we have significantly low p-value. The next one. These are the results of multiple logistic regression analysis trying to determine independent risk factors associated with various psychological conditions. I'm just going to briefly summarize. First part, compassion satisfaction, you can see compared to young participants, elderly employees have reported higher compassion satisfaction. Black and African American employees had relatively higher compassion satisfaction compared to other race groups. Those with prior mental health problems are at relatively lower risk of compassion satisfaction. So for burnout, it's the other way around. Basically, elderly participant had low risk of burnout. Those who provided care to COVID patients, those who had mental health problems or had their primary role changed during the outbreak are at high risk of burnout. For secondary traumatic stress, those who have family members or close friends tested positive for COVID, those with prior mental health problems are at higher risk. For PTSD, female gender, those who provided care to COVID patients who died, those who had family members or friends tested positive, those with mental health problems before, and those with primary role change during the outbreak are at high risk. For anxiety, female participant, those who had family members, friends tested positive, mental health problems prior to the outbreak, and role change during the outbreak are at high risk. For obsession with COVID, those with family members, friends tested positive, mental health problems, and role changed are at high risk. So consistent with the prior result, those with burnout and secondary traumatic stress are at high risk of getting PTSD, anxiety, and obsession. Next one.
Can
So,
everybody mute, please? Can everybody mute if you're not speaking? Thank you.
so overall, we think healthcare workers are in an exceptional situation as they have to deal with unexpected emotions from both the patients and themselves. And we think they should find strategies to manage the stressors and anxieties of confronting prolonged illness and suffering. So the finding of high compassion, satisfaction, and low compassion fatigue, we believe is related to their motivation to alleviate the suffering of others, but these might have exceeded their ability to deliver the care needed, especially in the middle of this pandemic. As you can see, we still have prevalence of psychological disorders like depression, anxiety, PTSD among healthcare workers. Next one. So in summary, we find high grade of professional quality of life evidenced by high compassion satisfaction and low compassion fatigue among our healthcare staffs. We believe it's their testament to their courage and commitment to patients. The prevalence of PTSD and obsession, especially among those with prior mental health problems, female gender, younger age, those who provided care to COVID patients who died, or those who have family members tested positive, are like significance of improving well-being in our profession. Well, our study attempts to identify the at-risk groups I mentioned above among healthcare workers. It is clear that we think organizational intervention should be implemented to help healthcare workers maintaining their care attitudes, and promote self-care. Thank you.
That was wonderful, Dr. Yu. Very, very interesting. So we'll open it up to people with questions. You can either unmute yourself and ask the question or type it into the chat page. While we're waiting, I'll just ask Dr. Yu, so you did find some people who were suffering a lot. Was there any kind of follow-up with those people?
So our study is more like a cross-sectional survey. It's sort of hard to track them. But basically, like I said, the survey was conducted from May to July. That was right after the outbreak. So sort of like the period when people actually started suffering from PTSD, anxiety from the traumatic events during the outbreak.
Okay, thank
So
you.
like this is like a brief like a description of what's going on with their mental health among healthcare workers, which might give some insight to healthcare leaders or hospitals to get prepared for the next outbreak.
Wonderful, thank you. It's like a snapshot. Yeah. Any other questions?
Dr. Yu, are you thinking of repeating this surveys with the same group in March to July of 2021?
Obviously, that's a good idea. I think we can do that, and we can make some comparison because we are actually undergoing the second outbreak, and see if there's any changes, since I think our hospital implement some measures and support given the experience from the previous outbreak.
Thank you, Dr. Truesdale, for that question. Any other questions for Dr. Yu?
Yes, there is one more question from Hans Starhurst. It is, what interventions might be considered to prevent burnout? What has been tried elsewhere?
So I think what part of the result we show certain people at like certain groups of people are at higher risk. There are definitely a lot of things we can do. For example, we found like younger staffs were at increased risk. That might indicate probably medical students, residents need additional support from their mentors or like peer support structure. Female gender tend to get anxiety, PTSD, probably because they have children or kids to take care of at home, like the schools are closing. So they are like suffering from extra stressors. The hospital might be able to do something for that. Obviously, we found like people with prior mental health problems at risk of all kinds of these psychological disorders. So probably a hospital could provide additional support like psychological counseling for those staffs at risk, or give them like a sort of lighter tasks.
Interesting. Thank you. Thank you for the question. Thank you for the answer. Okay, let's move forward to our second presentation.
Thank you.
This is presented by Dr. Rhonda Truesdale. It is the New York City Precision Medicine Consortium and the All of Us Research Program. Take it away, Dr. Truesdale.
Thank you. First, I just wanted to say thank you for inviting me to give a talk about the Precision Medicine Program and the All of Us Research Program. My day job, I guess I should say, is being an endocrinologist at Harlem Hospital, but I'm also a principal investigator for the All of Us study with the New York City Precision Medicine Consortium. And this consortium consists of Columbia University Medical Center, Weill Cornell Medicine, New York City Health and Hospital with the home base at Harlem, and New York Presbyterian Hospital group. Sorry, I'm trying to There we go. Next slide. So what is precision medicine? Precision medicine is defined as an emerging approach for disease, including both treatment and prevention, that takes into account individual variability in lifestyle, environment, and biological makeup. One of the examples we like to use of precision medicine that's happening in 2021 is glasses. So people may have vision problems for a variety of reasons. They may have astigmatism, they may have some cataracts, they may have nearsighted, farsighted, and each of the individuals who need glasses will likely have a different prescription that helps them see their best. And so I may have a different pair of glasses than the other people that are on this call. Also, you may have a difference in the right lens and the left lens. So we can get very specific about how we help someone see their best. Unfortunately, the majority of medicine is not like glasses, and it's more based upon clinical trials of a relatively homogeneous population that kind of tells us information about what is best for most people, but doesn't necessarily tell us what is best for an individual person. So the All of Us research program was developed to create a research platform to accelerate precision medicine research. Now, I really want to point out here that the All of Us research program was not designed to study a specific disease. It's not studying only cancer, only diabetes, or only CHF. The idea is that we would develop some tools and bring those together in one place so that researchers all across the United States, and probably eventually all across the world, would be able to use these tools to ask questions that are most relevant to their own patient population. So how are we doing this? First, we are planning to enroll 1 million or more participants from the United States. Right now, it needs to be adults 18 and older living in the United States who can consent for themselves in either English or Spanish. We are in the process of developing additional languages, and we're also trying to get pediatric patients included in the study, since that would give us the broadest timeline for following them. So what kind of information are we putting into this platform? Well, we're collecting a lot of standardized data from a variety of sources. So we're asking participants to fill out surveys about a variety of medical issues. We're asking for access to their electronic health records, not just a one-time look, but for going forward as well. And physical exam measurements are taken in a standardized way at all of the programs across the United States. Biospecimens of blood and urine, and oftentimes saliva, are collected, and those samples are sent to the Mayo Clinic for storage. The participants can provide information and connections from their mobile wearable technologies to have that uploaded into the system as well. And many of the participants expressed an interest in geospatial/environmental data and how where you live and where you work may affect your health. One of the priorities for this program is to have diversity. So we're reaching out to diverse populations and communities that have historically been underrepresented in biomedical research, fondly called Ubers. How are we doing with enrolling people and trying to reach our diversity goals? Well, nationally, 440,000 people have enrolled and are in some process of the enrollment process. 272,000 people have completed all the steps that we require in order to be considered a core participant. In New York, 30,000 are in some point of enrollment, and 26,000 have completed all the steps to be a core participant. And one of the things we're most proud of is that over 70% of the people participating in the All of Us program are considered to be underrepresented in biomedical research. So this is a very diverse group of people that we're collecting a lot of information on to try to understand more about individuals and how they're going to respond to treatments and what they might be able to do to prevent disease. Next slide, please. So next, I want to turn to two relatively new but exciting projects that are going on with the All of Us program. So first of all, DNA analysis has started. We're looking at 3 specific types of analysis. First, ancestry and personal traits. This is the information that people normally get when they sign up for 23andMe or Ancestry.com. We're also looking at pharmacogenetics. So as this becomes more important as people start to take multiple medications together, as we want to know, are there genetic differences that will change how they metabolize medications, and maybe what medicines we should make sure we're not giving together. And that would help try to personalize getting the right medication to the right person on the first try, rather than trying to try out different medications. Sequencing. So there was a large discussion about what type of sequencing of DNA that we would perform as part of the All of Us research program. So normally when you order a clinical genetic test in the clinic, you're only targeting genes that are related to the patient's presentation. With whole genome sequencing, you're looking at the entire DNA genome from A to Z. So we're collecting it and storing it and making that available to the participants should they choose to be interested in that. So participants can decide if they want none of their data, if they only want ancestry and personal traits, only want genetic sequencing or pharmacogenetics. It's really up to them what information they would like to receive. If the participant decides that they want to obtain sequencing data, then the information that's provided to them is not every single variable of every single gene that may or may not be important, but we're only reporting on what we consider to be actionable variants. And that's gene changes that we know will affect clinical treatment or clinical monitoring for the participant. And currently there are 59 actionable variants that have been identified. Probably the most famous is BRCA1 and BRCA2, which increase the risk of having breast cancer and or ovarian cancer. Now we know that most of our participants are not fluent with genetic analysis, and we also know that this is a big decision for many people. So the All of Us study is providing free genetic counseling services for participants. This is generally a phone service that's being provided. And this is to help assist the participants in making decisions about whether they want to receive genetic results and whether the answers the family has, answering questions the family may have about genetic results, but also talking to providers to help their patient make this decision. And if someone decides that they want to receive their genetic results, the participant, the family, and the provider can also call back with the genetic service to have follow-up recommendations and understand better what these results mean. And additionally, the All of Us program is going to be sponsoring a geneticist at Harlem Hospital to assist with understanding the results and coordinating any care that may be needed for an actionable variant. Next slide. The second project that we find exciting is the Researcher Workbench. So how does the Researcher Workbench work? First, participants share their data with the program, as we've discussed. All the data are sent to a secure cloud environment that's managed by the program's Data and Research Center. Once the data gets to the Data and Research Center, they funnel all of this data through a curation process and put it into a secure data repository. This repository, one thing that's missing from this is that they also make sure that all of the data is standardized so that the data that you're looking at in the repository is compatible and comparable. So we know that like a patient who gets care at Health and Hospital has QuadraMed data and Epic data. The DRC has a way of bringing that together and having it work in one system. So once it goes to the Research Hub, anyone can visit the Research Hub that is available online, and it's available at, oops, I used to have this on here. It's available at researchallofus.org. And anyone can look at this. Your grandmother can look at it. Your brother-in-law can look at it. Everyone can look at it, because the data that is on the web with is all aggregated participant data. So it's not possible to determine any specific participant in the program looking at this aggregated data, but it does provide interesting information about what types of surveys, questions were asked and how do people respond to that, and looking at what types of diseases people who are participating in the program have. So it's a great way to get a feel for what's going on with this program. Now, if you want a more individual look at the data, then you can sign up to be a registered researcher. So in order to access the Researcher Workbench as a registered researcher, you have to go through a process that they describe once you get on there. Once you're on there, then you can use collaborative workspaces, cohort building tools, and interactive notebooks in order to ask a question that you're interested in and see how the data can help you answer those questions. I want to point out that the NIH, again, understands that everyone may not be a data guru, and so they provide extensive research support for people who are participating in this program. You need to have an institutional agreement, and I'm happy to say that New York City Health and Hospital has signed an institutional agreement to allow all the PAGNY investigators to have access to the Researcher Workbench. I will say that the final signing of the agreement has to be done by Vanderbilt, and they are a little bit behind on their paperwork because they've had such a great response of institutions, even institutions that are not participating in the All of Us program, who are interested in working with the Research Workbench. Once we have everything in place, we will certainly be happy to let you know. And the final thing I want to say is if you're interested in any of these projects or what's involved in enrolling people for the All of Us program, please give me an email at rhonda.truesdale@nychhc.org. Or contact the PAGNY group and they'll get you in touch with me. Thank you so much for your time.
Thank you so much, Rhonda. We will send the slide out in whole with the email addresses that Dr. Truesdale just mentioned. So be on the lookout for that. Okay, any questions for Dr. Truesdale? That was a great presentation, very exciting. Great that we have new data to work from.
We have one question from Ms. Olga Diaz. Good afternoon. Is it available for a research coordinator to be enrolled to this research program?
Enrolling in the research program, everyone is welcome. I keep trying to remind the people at Harlem that it's not just for the patients, it's for everyone. We need a broad range of people. If you're asking specifically about the Researcher Workbench, then yes, you are able to apply to be an investigator on the Researcher Workbench.
Fantastic. Any other questions? Okay, we will send Dr. Truesdale's information out to you so that you can email her if you're interested in any of her projects. This was a fantastic session. Thanks, everybody. Again, just a reminder, here is your CE code that you will need to sign by tomorrow at noon when it expires. So wonderful. We look forward to seeing you Friday, many of you on Friday, for another session. Thank you to the presenters.
Thank you.
Take care, everybody. Have a good afternoon.
Thank you.